Dr. Hudson Nakamura.
I would like to express my gratitude for Dr. Hudson Nakamura for arranging the next session, and please let us introduce the first speaker. Yes, we are inviting, that's the greatest pleasure, to invite Dr. Francina Gagarino, macular buckle or vitrectomy. When to choose is the right answer. Hello, and the floor goes to you.
Hello to everyone. Thank you for this opportunity to be talking to you today. And just a second. Okay. Today we're going to talk about the macular buckling or vitrectomy for myopic macular traction maculopathy, when to choose or if is there a right answer. And for those who are not used to this terminology, traction myopic maculopathy is a spectrum of macular change in high myopic eyes that leads to a progressive separation of retinal layers, how it's called maculoschisis. It happens in high myopic eyes, especially those with more than 28 millimeters of axial length, and it's more common in female near to 5th and 6th decade. And we really don't know why the eye starts growing again and then the staphyloma progress. It may progress to foveal detachment, full thickness macular hole with retinal detachment or retinal detachments. And it happened because this is a disease driven by composition force. We have this vertical and tangential force acting over the eye, and we have a poor capability of stretching of the retina. So the imbalance between inward and outward forces leads to the retinal splitting. The MTM severity is related to the anatomic findings, so we have to consider the choroidal thinning, retinal rigidity, posterior staphyloma configuration, and the scleral poverty mismatch. And of course, it's easier to deal with this kind of anatomy than with those kind of anatomy where you have a very big staphyloma. And as previously shown us by the Korean group leading by Professor Woo-Choo Park, we have the compound form of wide macular posterior staphyloma. You have a big staphyloma, but then you have this compound form that it's a great structural deformation. We have more severe myopic change, and we have worse visual prognosis, especially for those who underwent retinal vitrectomy and failure of this previous surgery. So this is considered the advanced form of staphyloma. And why macular buckling? Because macular buckling counteracts the posterior staphyloma. It was first described by Scappings in 1957, and some colleagues after that tried to idealize new explants, and then when the 80s came with macular vitrectomy, it was a decline time. So back in 20s and more recently, other colleagues already proposed new kind of explants in this technique because of the failure in vitrectomy for high myopic eyes, because 20% of these eyes failure at the primary surgery. So Padolini and their colleagues, they proposed the MTM staging system, refined buckle design, and also combined techniques. And as we can see here, the proposal which one would be better with only macular buckling or macular buckle plus vitrectomy. We also published our insights and our experience in Brazil. And because all of this complication that happens, I think that we have to consider the surgical strategy based on anatomy, because choosing the best surgical techniques depend on the globe anatomy and the macular finds, because if you have different forces, you have to think about different surgery. So in the 90s also, Professor Nakamura also published the scleral indication. There's a nice technique that we reduce the length of the eye, but also after Professor Hono Matsui in the group with Professor Shimada, they showed us this beautiful technique that is the IOM peeling circumferentially. The name is foveal sparing IOM peeling, because if you have maybe the possibility during the surgery to create a full thickness macular hole, so you should think about leaving the IOM over the fovea, not to open macular hole. So what you do is to remove the IOM and leave it over the fovea, and then do air fluid exchange gas. But when we are dealing with this kind of anatomy, this kind of high big eye, you see here that this eye is very long. This is a sky OCT that you can almost we can have all the posterior pole in an image that's not easy with other kind of OCT like Heidelberg that we have also. So this is of help. And here you can see that we have a full thickness macular hole and this staphyloма very big here, and also this compound form here. So in this case, what we did was to perform a macular buckle. We create a one macular buckle here, and we start opening the conjunctiva, isolating the muscle. Then we put the buckle under the macula, and we try to we check if it's in the right position with the chandelier. If it's in the right position with sutures, with double suture, because we leave the small part of the sleeve to protect the buckle. And then we perform the vitrectomy. We dye with Brilliant Blue, remove the posterior hyaloid, and those eyes with high myopia, these eyes with high myopia anatomy, they have multiple layers of epiretinal membranes, hyaloid skin, I don't know how we can name it, but you have to be sure that you have peeled all of them. And it's nice to peel very widely, because like this you can remove the stretching, removing the pores that are stretching the retina. And then in this case we finished with silicone oil, because she was faking and we didn't want to do with the cataract at the moment. So you can see here that we have a very beautiful result. The buckle is positioned here. We didn't reduce so much the length of the eye, but we really try deal with the staphyloma, as you can see. And in some cases, what we do also is, when you don't have a full thickness macular hole, as proposed by Caroline and their colleagues and her colleagues, we can just put the buckle under the macula. So the objective is to reduce, like you can see here, reduce the staphyloma, and then slowly the anatomy goes back to the right position. And for those who think that macular buckle leading to macular atrophy, also the group of Professor Hono Matsui has shown that, and as Gaz has shown us very long before, that they are progressive for atrophic macular atrophy in high myopia eyes, and it doesn't have any correlation to macular buckle. And the point is, when I think about all of this, I think we have to make a decision in tailored surgery, which course we need to treat. So if you have predominantly internal tractional, we should think about only vitrectomy. But if you have this anterior-posterior traction with a high big a compound form of wide macular posterior staphylomas, you have to consider macular buckling or even failure in the previous surgery. And in mixed case, combine an approach. Consider that one technique does not fit all the cases. Thank you so much.
Thank you so much for this wonderful presentation. We have a question from our audience. Just 1 minute. We will give the mic to the person. Thank you very much for this surgery. Thank you for those interesting cases presented. My question, whether in those cases there was a buccal extrusion. Did you see in the long term the extrusion of the buccal?
Well, not in my cases, I don't have a very long history of macular buckling. I started doing 3 years ago, and I have more or less 10 cases, and thanks God I haven't had any kind of complication. Yes, we can have, for instance, diplopia. We can have strabismus, a small portion of strabismus. Dr. Parolini also proposed that she has how can I say? I forgot. A contact lens that can deal with this diplopia. But the case that we did were cases that were the visual acuity was not so good, but people are stable, more or less 20 under 80, 31, 20 under 100. And for these patients, they are doing well with this.
And another question, just to add, additional question, whether you took the buckles out in some period after the main surgery. Were there cases that you took the buckle out?
If I had to take the buckle out, is that it? I didn't have any complication and I didn't have to take the buckle out of any patient until now. And sometimes you can, I don't know if I answer you well, but I don't know if the answer is doing the surgery, because you put the buckle and then you check with the chandelier to see if it's in the right position. What I do is to do a little movement. You need to not to be so aggressive, because you can have, for instance, choroidal hemorrhage. So you do the slight movement, or even you can put the chandelier together with your buckle to see it in the right position. But until now, I didn't have any complication. We do it with very tender gesture, and for now, everything is okay. We have 3 years and a half of follow-up of these patients.
And briefly, one more question. Thank you once again for this wonderful presentation. Can you tell us how long did you keep the silicone tamponade, and when did you take the silicone out?
I usually keep the silicone for 6 months and then I take it out. We have now a suggestion of taking it earlier, but in this I prefer to leave for this time. I use the silicone in specific cases. I think it's easier if you can go under gas. But in this case, especially, we have she was faking. We preferred silicone oil.
Thank you ever so much for your presentation and your answers. Thank you for joining. Thank you for your time. And the next speaker is Dr. Alan Franklin from the USA, Intraoperative Angiography in Diabetic Retinopathy and Severe Cases of Retinal Detachment. Happy to welcome you, and the floor is yours.
Well, thank you so much for the opportunity to talk at this great meeting and event, and also appreciate Dr. Nakamura allowing me to talk. I share my screen and I'll cue my talk up here. So I'm just doing 3 interesting cases. The first case is basically, we've been working on fluorescein angiography. Typically, we've been using the Alcon system, which is a great system, but the question is fluorescein angiography, how does it work on other platforms? And so I'm going to basically show, this is the Bausch & Lomb platform. So this is the Stellaris. We've got the exciter filter in the Stellaris. We're using the Ingenuity monitor here, but this is light from the Stellaris, and it works nicely. It's a diabetic, and you can see microaneurysms. This is the Constellation, but we've got the C-Luma as the monitor. And the C-Luma, the image is a little softer. It's not quite as well defined as the Alcon system, but overall the image quality is very nice and the depth of field is great. Everything's in focus. So, we were able to see very well with the C-Luma. We were able to project light well with the Stellaris. We're also working with Dork Zeiss to get their platform up and going. So in the next couple of years, hopefully we'll be able to see that if you want to do intraoperative fluorescein angiography, it can be done on a number of different platforms. So this is the case, multiple surgeries done elsewhere. This is just kind of a complex case. And there's, right by the nerve, there's a large hole. There's some very adherent inferior PVR. This patient was previously buckled. So what we're doing here, there's some degree of foreshortening. We peel PVR membranes and then we're doing a retinectomy. But in addition to doing the retinectomy, we're cutting a patch graft. And you always want to cut more of a patch graft than you think you're going to need. I think we're doing this 27 gauge, so rather than using a scissors, I'm just using the cutter to cut the patch graft. I was peeling some inferior membranes, putting in perfluoron. I really like perfluoron because if the retina goes flat under perfluoron, it's going to tend to stay flat. And on this case, here we're positioning the patch graft. We left this patient under perfluoron for a couple of weeks, and then we switched to gas. And this has really worked well in our hands, even for the retinal foreshortening, especially for inferior pathology. This medium-acting perfluorocarbon tamponade just works really well. And so we've kind of released the traction temporally. There was still some foreshortening inferiorly, and we made a few retinotomies. This is watch Kuros Razai present this, where rather than making a big retinectomy, you can make a few retinotomies. If the retina is only a little foreshortened, the retina flattened nicely. This patient is 2.5 months out. They went from beer-like perception to 2800, so they're doing well. The next case is certainly a case that I'd love to hear feedback on. Let's say diabetic, severe diabetic retinopathy. The one eye is maybe 21,000 vision. So the second eye is getting a worse and worse tractional detachment and vitreous hemorrhage. And these eyes, to me, are a real challenge because the membranes, they're not just the typical pegs of neovascularization. There's just a plaque on the retina, and the underlying retina is very atrophic, and with just minimal traction, the retina can tear. Here we're using fluorescein angiography to try to better delineate the pre-retinal membranes. That helps somewhat, but we're able to get a plane starting in the macula. But here, this is just kind of a mess. Wherever we're pulling, everything is stuck, and we're trying to release the traction with just very gently by manual dissection, but we're still running into atrophic underlying retina. I did the the back cutting technique. We're pulsing with shortcuts on the cutter. You'll see here just how tenacious these membranes are. So this is one where, how much do you peel? I kind of felt like I could get most of this off relatively atraumatically. We then are doing fluorescein angiography just to look at, is there any occult neovascularization or hot spots? And here we found some fluorescein leakage. And if we do if we treat this leakage, which sometimes we can't see with just conventional microscopy, it reduces our vitreous hemorrhage rate significantly postoperatively. So we got the retina flat. On these patients, I'm injecting methotrexate, and that really seems to help recurrent preretinal membrane formation. But certainly we could have tried to just clear the macula or the posterior pole and done a bunch of laser. I've had mixed results with that, but again, certainly I'd love to get feedback from the panel and others as towards what's the best way to approach these eyes. So thank you so much.
Thank you so much. One question with regards to methotrexate. Where exactly do you inject and how?
That's a great question. Methotrexate, I had been doing 4 injections of methotrexate postoperatively at post-ops week 1, 2, 4, 7, and 11. Chris Riemann has done a really nice study on primary retinal detachments where he has looked at detachments with no methotrexate, detachments where methotrexate is given intraoperatively and no post-op injections, patients who had no methotrexate intraoperatively but who have post-op injections, and then patients who have both methotrexate intraoperatively and then 4 or 5 post-operative injections. And not unexpectedly, the patients that do worse are the patients that get no methotrexate, but he found some recurrent detachments in the groups that had methotrexate either during the surgery or after the surgery, but not both. But in the group, and I think that's about 20 or 30 patients who had methotrexate during the surgery and after the surgery, there was 0 recurrent retinal detachment, which is pretty striking. We give the methotrexate intravitreally, standard intravitreal injection, 200 micrograms. We found the reduced dose works as well as the 400 micrograms and has less corneal toxicity. But it's a standard intravitreal injection, and I'm just doing the intravitreal injections at the end of the surgery. Chris has got methotrexate in the infusion fluid, but some of the hospitals don't like that much methotrexate in the fluid, so I'm just doing an injection at the end of the surgery and then in the office.
Thank you very much. A short comment and then we will move on. Thank you really so much. It's a complicated surgery, especially in such severe cases of diabetic retinopathy. Unfortunately, in our country, we do have a lot of cases like that, and even more. And tractional detachment and traction rheumatogenic as well. Maybe it's related to social status getting worse, but I agree it's a very difficult surgery. So thank you very much for a wonderful case that you have demonstrated. And my question is with regards to intravitreal injections of anti-VEGF, how often do you use them before vitrectomy, and how many days before vitrectomy do you use them?
That's a great question. I do intravitreal anti-VEGF. I try to do them before all of these difficult vitrectomies. And as you mentioned, a lot of these patients, they have social or compliance issues. So I like to do the injections about a week before surgery. But sometimes we can't get the patients in the operating room that quickly. So I tend to do the injections, and I'll use half strain Avastin to reduce risk of crunch. And that way, if they're 2 or 3 weeks out, they don't fibrose worse.
Thank you so much again for joining us. Thank you for participating in the symposium, and all the best to you. We move forward to the next speaker, and we strongly hope we can meet you in the future. Thank you so much. And now we greet our colleague from Greece, Athanasios Nikolakopoulos, and we will speak about retinal detachment when the lens is hiding behind the retina, dealing with the patient who was referred to us and making the patient happy. Thank you, and glad to greet you.
Перепрошую, перекладач не чує спікера.
I'm sorry, your microphone doesn't work. We cannot hear you.
Let me change it.
О, дозвольте зміню налаштування. Ось.
Починає
Is it better now?
працювати. Отож, чи краще?
Is it okay now?
чути мене?
We can hear you. Thank you. Yes, we can.
Okay. I would like to congratulate because I saw the program.
Вітаю.
It's
я
very dense
бачив
and very
програму.
updated.
Така насичена програма.
And I'm looking forward to see you from here when you feel much better and peace is all over your place because you deserve it as much as anybody else, but more than anybody else this time. And congratulate you for your efforts.
А я пана скінчила, я виїхала, я вислухала.
Вітаємося з вашими зусиллями. Це прекрасно.
Dovete fare benissimo.
So, can I start?
Отож, чи може я
Давайте
розпочати?
пишу.
Добрі слова. Yes.
You can.
Yeah,
Let us start.
let's start. And
Чудово.
treating a cataract complication, that's a story of my life. And it has to do with how to do things from my personal experience over a few years ago, that means about 40 years. Treating cataract complications, that's a personal experience. It doesn't have statistics at all. It's not proven what I'm going to say, but it's coming from experience only. And I'm sorry for that, but I'm happy to share with you what we're doing. So, what is the basic complication? It's retained lens fragments. And this is the basic thing that we have. So the risk factors are usually when you have a very dense cataract, when you have a posterior polar cataract attached to the vitreous, when you have zonular weakness, floppy iris syndrome, diabetes, trauma, and vascular vitrectomy. So we always say in my country, before you start anything, learn how to finish it. And this is very important when you start something to learn what is expected from you. Let's start with a posterior capsular break. Let's take it step by step. The first thing they do is they increase the infusion sometimes in order to fill the eye, not to lose anything. But do not please lower the infusion, because the low pressure in the anterior chamber, a vitreous from the back goes anteriorly. That's a common physics law, and you cannot fight it with any statistics. So if you lower the infusion from the beginning, then the anterior chamber is going to be less pressurized and vitreous is going to come, although it was not supposed to come if you didn't lower the infusion. So you need the infusion extrusion to understand the infusion extrusion stability. What is posterior rupture plus vitreous loss? Another thing that usually people used to do is to put sponges and cut the vitreous with sponges lifting from the cornea, and that means that the traction is particularly done at the base of the vitreous, but they do the damage later, many months, a year, 2 years later, because of the traction at the posterior base. That means tears. Vitrectomy from the ports using anterior chamber maintainer for the infusion also is very bad to do. It's very good to do using triamcinolone. I mean, painting the vitreous, knowing what exactly you need to remove, going from the side ports using an infusion cannula from the side port. Then you can clear the vitreous completely from the anterior chamber. That's the first step to do. The second thing is how to remove this vitreous. The thing is, you do vitrectomy from side ports, but you need to reach the anterior plane, posterior plane of the iris, the anterior plane of the iris. Do not go blindly behind the pupillary, because this way you attract more and more vitreous to coming eye in front. The other step that usually my fellows are doing is that they overfill with viscoelastic the anterior chamber in order to completely push the vitreous back. But if you fill something that has a posterior capsule breakage, then the vitreous is going to go posteriorly. And you know what it means? It means that the next day you're going to have 60 millimeters of pressure, because the vitreous cannot be removed from the posterior chamber. And remember, another issue is that now the anesthesia of a plain cataract, if you don't suggest that it's going to happen anything, it's drop anesthesia. So that means you cannot manipulate the eye more than that. So you need to block the eye for the complication, not to have the previous blockage you've done for the so you can do a subconjunctival injection at the time in order to continue without the patient to be in pain, to move, squeeze the eye and everything, and make sure, and you have to inform the patient is going to take a little bit more, and never talk about complication on the head of the patient. Imagine that you are in a surgical room, we are the patients now, not the doctors, and somebody doing something on the top of us for surgery started saying, oh, sorry, no, oh, shouldn't happen, don't do that, but talking on the face of a patient, on the ear of a patient that is under local anesthesia, it's absolutely forbidden. So if you make the wrong decision, what are you going to have the next day? You're going to have a very high intraocular pressure, painful eye because of the viscoelastic. You're going to have a wide cornea if you won't be able to see anything. and a very strong patient reaction to the thing that you said him before, that it would be a 15-minute surgery, and then you drive back home.
Сказали, що це 15 хвилин
So you have
операція, а далі
painful
їдете додому.
blind
Тут
eye.
буде психологічний проблем у пацієнта.
But if you have a drop nucleus or parts
Якщо
of
у
the
вас
nucleus,
опущене
you should not fish behind the eyes. Never leave it and let it drop in the posterior of the eye. And at least you're going to save endothelial cells, but not doing any things in the anterior chamber so much. And if possible, if you have all the procedures that I told you before, you can put a sulcus IOL at the end of the procedure. Although you left the nucleus in the back of the eye, I would suggest, against a lot of people saying that, a sulcus IOL, because then the patient would be able to see something next day.
І пацієнт зможе, в принципі, бачити.
If you do this approach that I am suggesting, the next day you are going to have no intraocular pressure. That means no severe pain. You're going to have a clear cornea for further vitrectomy as the next step. And the patient can see and give you the time to explain what happened. Oh, that's essential. Not the patient feel that you blinded him. So this is an extreme example of how things can go wrong when the patient, when is fishing. Sorry, it doesn't actually goes. There it is. You see, we have a patient, we have a nucleus gone in, and somebody told us fix it. We always use a chandelier light for bimanual surgery, for posterior sigma surgery. I love that thing because you need both hands. So while we did the vitrectomy, we couldn't find the nucleus, but we find the inferior detachment.
Але побачили,
So where's the nucleus that is supposed to be there?
воно ж мало бути тут.
So little by little, by cleaning the vitreous, we saw that there was a tear at the area posteriorly there, that it looked small enough, but it's a tear, that's why producing a retinal detachment. And we decided to search the area and remove the vitreous behind this area. And we got a big surprise. A nucleus that it was much bigger than the tear was behind the retina. And you can see the birth of the nucleus coming through the tear in the middle of the eye. Look how huge the nucleus is and how small the tear was. And we explain that by saying that, you see, it has started the vitrectomy in the middle and then it dropped. We see the negative traction that is done when you squeeze the eye. When you squeeze the eye, you actually suction things when you make a tear. And so by suctioning and now we got another problem. We got a retinal detachment and we got a nucleus in the middle of the eye. And we should not teach the retina. We should not inject perfluorocarbon liquid to flatten the retina because it's going to go behind there. And we have to remove the nucleus. And we did it with phaco. And the two axiomas that I have developed through my experience, the one is when you do anything with the eye, you need to have the faucet, but you need to hold it with the right hand, and with the left hand the vitrectomy or the phacoemulsification probe, because you need to control the lens, the nucleus not to touch anywhere. I never remove anything that's sitting on the retina. If it's sitting on the retina, it's got to be lifted, and it has to be removed all the vitreous before you start cutting the nucleus. As you can see, the rotation of the nucleus inside the eye, that means that you already removed all the vitreous around it. And then whatever you do it in the middle of the eye. You should not touch anything. Another thing about end-of-phaco emulsification is that you need to hold the lens and zap it a few times and keep the end of the phaco emulsifier always inside of the nucleus, because if you do a lot of intense phaco emulsification inside the vitreous cavity, then if it goes through the nucleus from one end to the other while doing the tapping, then because you have a 19 gauge usually and a 25 gauge infusion cannula, you're going to suck fluid, BSS, that you got inside the eye, and you might have a choroidal detachment of the sudden loss of pressure. So the end of your probe that is doing phaco emulsification inside the eye should never leave the nucleus unless it's stopped. You cannot suck BSS while you have this thing. And at the end, you make small pieces and you take them by being patient and you remove everything. And if you remove the nucleus to fix the retinal detachment, it's very easy. But we thought that was it. We made it. We fixed it. Let's go a little bit sooner. And at the end, it's clear. The retina is attached. And now, what happened? The descemet has been removed, has been mobilized. And we have to suture the descemet that we saw it at the end because of the introduction of the probe for the phaco trying to fish the nucleus. They have removed the descemet. And it was floating. So if you leave the descemet floating, you're going to have a trouble. And the only thing you have to do is to put a suture through the cornea and the descemet. And this is, and I have just to make an announcement that in Thessaloniki, together with Retinawesome and a lot of other surgeons, we have the Thessaloniki Retina Summer School where we teach how to face the complications and how to do things that are not actually on the book or on the internet. And we usually have 20 surgical positions. And this is the setup we got, the latest, and it's closing to a whole week of training, only wet labs, for 30 hours, almost 36 hours wet labs. And the next one is going to be 29th of June and 4th of July. And I hope you can, if people would like to know, you can join us. And I would like to thank you for accepting me to your beautiful group you're having. And I hope we'll get a better future together. Thank you.
Thank you so much for this great presentation. Really very complicated case you had there. One question, you had so many sutures there. Had there been any other complications that you used that many sutures? Corneoscleral sutures.
Everything you saw was done by the cataract surgeon.
Те, що ви
The step by step from the cataract surgeon is that he tried to fish the nucleus going behind the eyes. Did all the damage by throwing the nucleus inside. And then he was trying to extend the cornea in order to put an anterior chamber lens of 6 millimeters. So he made all the wrong decisions. So he had to put all these sutures. So the sutures were found there. And while getting in and out of the eye, trying to fix the problem, he also made a descemet detachment. So all these things are happening because he didn't stop when he had the complication. Clean the anterior chamber, remove everything is in the anterior chamber, and leave the eye alone to a deep retinal surgeon. He tried to fix it, And so I call it stop fishing. No fishing behind the iris plane. This is my motto. Behind the iris plane, you do nothing because you cannot see, and you make all the damage because there is the vitreous base. And pulling the vitreous base, you make a tear. Making a tear, you make a detachment. And if you don't make a detachment this time, you're going to make a detachment after 2 months, 3 months, 4 months, 1 year. And they say it's your complication. That's why you have so many detachments after complicated cataract cases. So this is my advice to fellows that are trying to do cataract and they have a complication. Don't panic. Anesthesia, induce the anesthesia more and relax the patient. Don't shout on the head of the, don't make any comments. It's very important. This is crazy. I mean, imagine somebody operating you and say, what happened? Please don't do that. Don't move. It's getting crazy. So you've got to have a relaxed patient. You got to stay on the plane of the anterior chamber. You got to remove everything from the anterior chamber, and then leave the patient alone. Sorry for being so passionate about it, but
Thank you for your invitation for your school to come to your school, and hopefully that Ukrainian ophthalmologists, young doctors would be able to join in. Thank you so much. We'll be happy to see you next time at our meetings as well.
I hope so. I hope so, and I.
Дуже сподіваюсь.
Thank you.
All right, and we are moving on. And now about severe fibrovascular membrane in adult surgical treatment patients with one eye problem. Dr. Ahmed Habib, Egypt.
Yes, hello everyone.
Greetings, and the floor is yours.
So is it on?
Так, вітаю.
Okay.
It's on.
Okay. This is a case, actually, an extreme case of familial excessive vitreous retinopathy fever in a 16-year-old young lady. This is one of the most severe cases I've seen in this age group with familial excessive vitreous retinopathy. So this is the right eye. The vision was hand motion, and this is the left eye, which is nearly lost with PL bare projection. So I decided to give a chance to the right eye, and in these cases usually I enter with the same plan as the diabetics. But here the difference is that the vitreous is transformed into several layers on top of each other. Due to the prolonged exudation. So I do the core vitrectomy and cut the connections between the posterior pole and the periphery, and then I proceed to do something that I call the mid-peripheral PVD, which is inducing a posterior vitreous detachment from the mid-periphery between the vitreous base and the posterior pole membrane. I try to do this 360 degrees and trim the membrane. I also use triamcinolone to make sure that there is no vitreous in this mid-peripheral zone, and then I proceed to do the shaving. I do the shaving early on to get over with an essential step, actually, so as to be able to do the rest with a relaxed mind. Here I'm using bimanual vitrectomy and bimanual maneuvers, and I'm using this forceps is a loop design forceps, which has a protrusion, in one of the blades to use it as a pick to be able to lift and catch the membrane. and I'm using here the bimanual technique, which I usually use with posterior pole membranes. But as you can see, there are main differences between the diabetic posterior pole membrane and this posterior pole membrane due to the familial vitreous retinopathy, mainly because the origin of the fibroblastic membrane is from the periphery, not the center. Also, the prolonged traction causes folds. As you can see, the posterior pole is folded, and most notably, the disc is covered by the retina. This is because the nasal retina is pulled by the prolonged traction, so that there is a fold of the retina over the disc from the nasal side going to the temporal side, which is very important. I want you to take a mental picture of this because this is important to manage, and this is one of the important features of the fever as in general. And I usually remove the ILM just to make sure that there is no PVR over the posterior pole and no residual traction. And then I decided to do the intraoperative fluorescein angiography to confirm the diagnosis, and also to decide where the areas of the peripheral non-perfusions are. As you can see, there is pruning of the peripheral blood vessels here, which is a feature of fever. And then, guided by what I saw in the intraoperative fluorescein angiography, I did targeted laser to the areas of non-perfusion and leaving the other areas for her to see. This is the final visual acuity, which is 0.05, and as you can see, the disc is not covered now by the retina, or at least the fold over the retina is resolved in just 3 months. So the message here is just to remove the traction, try not to do any breaks, and the retina will recoil in a satisfactory way. Just give it time. Thank you.
Thank you really very much. That's true. That was a severe case and quite severe pathology and rare. Usually we can see massive epiretin membrane if we're talking about Febvre, but there are some rare cases combined with macular holes. Have you seen such in your practice, or you haven't?
Yes, sir. I have actually. I usually see the membrane arising from the periphery and causing distraction, but I really see the membrane creeping over the disc. I have seen actually these tractional macular holes, and you cannot treat them unless you remove the traction in the periphery.
Thank you. Thank you so much for your presentation. And we are moving on. Unfortunately, we do not have time, otherwise we would ask questions. But in future, hopefully, we will have this opportunity. So thank you very much again, and such a wonderful surgery. And before we start with the next Professor Hatsan Nakamura's presentation, on behalf of all Ukrainian ophthalmologists, from me personally, I would like to say thank you for sustainable support and for the participation in our OpthalmicHub conference, and thank you for organization of retinal symposium, the ability to discuss very relevant issues of vitreoretinal surgery. So thank you for that, and now you are most welcome to speak.
Hi, thank you very much for everybody's presence in the name of Retinawesome I really appreciate all your presentations, and I would like to make a short comment before I present my case. I loved all cases, especially from Alan Franklin and Ahmed Abib showing the fluoroscopic angiography during vitrectomy. We know it's a difficult task, difficult to do that, but Alan Franklin did this FA before actually the main vitrectomy, and Ahmed Abib did the vitrectomy afterwards. That was amazing to see that, good imaging and everything else. And the comments from Athanasius, especially for the general ophthalmologists and medical doctors and residents and fellows, and a great presentation from Francine as well. So I really appreciate. And I'm gonna show you my case. Let me just share the screen over here. Just a second. So let me discuss with you a very interesting case that I separated for this special presentation with OpthalmicHub. And let me start over here. And thanks again for the cooperation of all Retinawesome participants. And we are here another year, 2026. I was participating. This is my faculty. We've got attachments with the French Academy of Surgery, the Eye Bank Foundation, Goiânia, Brazil, Brazilian Vitreoretinal Society, and other societies as well. So we usually participate in special sessions in other events, and we've got no conflicts of interest for this presentation. We did this presentation in other sessions, in other events in Brazil, in India, and other countries as well. And this is into our Retinawesome DNA. So this is my technique. This is not the case, but this is one of the cases very interesting for this presentation that we presented first in 2019. It was in the iTube session. This is just some statistics on what I do in vitrectomy in cases that involve epiretinal membranes in blue and macular holes in green. So if the patient is too complicated to do anything, we just do a regular vitrectomy with gas, and that's all. But usually for patients that have the ELM build, we do not stuff in, so 0% for epiretinal membranes. So epiretinal membranes we don't stuff in, but for patients with macular holes, 25% of these patients, they deserve the stuffing technique or the ILM folding technique or any technique that I do, a modified one. But for most patients, 55%, they deserve for epiretinal membranes and one thorough air fluid exchange with one-time breathe and blue injection for the dye to stain either the ILM and or the edges of the epiretinal membrane, and for 40% for cases of macular holes. But for 25% of macular holes, we gotta stain twice, so we do double stain. And for 40% of epiretinal membranes, we dye twice because of retinal membranes and macular puckers. So the first appearance of these was in iTube in 2018, and then in 2019 25, we presented lots of cases. We started with the ILM peeling techniques. As you see here, we've got lots of cases, plenty of different cases that we do for vitrectomy, and every disease has a different thing to do. So the first case here, as you see here, the ILM folding technique was displayed in night tube in 2019. The surgery was 1 year before, and this is the first and ever made ILM stuffing technique with the tubular fashion way. So I call this ILM folding technique. There is no other publication showing this surgery as is the technique. So after some months, people started to stuffing, but not in this tubular fashion, this tubular way that I do. People started calling this stuffing technique, but this is not what people used to do until today, a stuffing technique. This is the ILM folding technique, the way I first made it. And we have lots of cases, plenty of cases like this one here, that we have several photographs in different situations, in diabetic retinopathy patients, in patients with macular puckers, in patients with retinal detachments, in patients that we do the ILM peel, epiretinal membrane peel with under silicone oil, in cases that we just stuff in, like this case shown in iTube. The last one on the right is a case that we did with perfluorocarbon liquid that helps us do that. And the second, from the left to right in the top line here, you see the case that I'm going to show you now. It's a combined retinal detachment and macular hole. So I call this the ILM seal technique for large and chronic macular holes. So that's the case. And sorry that I had my alarm on here. My session, our session, Retinawesome session, is supposed to be 1 hour, so it passed a little bit, but let me just turn it off, so that's okay now. So I start the case and I move it forward a bit. So we are at eye-bank foundation, vitrectomy with a whole cover technique or ILM seal technique. This was a 66 years old female, a phakic one, had some cataract and a small pupil. This was the right eye, and as you see, we start the vitrectomy here. You have this bullous retinal detachment, and the macula was partially on. If you see well, if you pay attention, there is a demarcation line that doesn't allow the fluid to go and detach the retina. That's why I started with very peripheral retinotomy in order to relieve and squirt subretinal fluid out of the subretinal space. You see the macula looks pretty better now, and without threatening the central area so as not to detach it. And using the perfluorocarbon liquid now, I attach it even more and protect the retina. At this moment, I'm going towards the retinal periphery to search for any defects on the retina, and in this case, I remove a bit of the almost all the perfluorocarbon liquid. So why am I doing that now? I'm removing the perfluorocarbon liquid, and I see the peripheral retinal detachment there. So the next step of the procedure is to go after the very retinal periphery and remove the adhered hyaloid that is there. As you see here, the hyalod causes some traction at the retina. So by removing further the hyalod, it's better that you don't get any tractions. And I'm gonna do a complete fluid exchange. I'm not worried at this point with the detachment, the peripheral detachment. It's not gonna increase. So I do a total retinal detachment, but the aim here is to inject brilliant blue so that I can see the internal limiting membrane to follow the next step of the procedure, which is to peel the ILM. Now, after doing further vitrectomy, I inject the fluorocarbon liquid again. And now let me go after the internal limiting membrane to do the peel very carefully. So what is interesting here is that I'm doing the internal limiting membrane peel and leaving the ILM, I would say, on the floor, right there where you can see. So by completing the peel the most circular possible around the macular hole and very slowly and engaging the ILM with care, and you have the fluorocarbon liquid that helps you have a better control of your peel. And I'm approaching the ILM, as you see here, towards the macular hole, and the poke, the central part of the internal limiting membrane is there, and you have two arms that come out of this central part. What the purpose is of these two arms, two stalks of the internal limiting membrane, is that they keep the retina stable, and after they heal, they're going to contract and help close the hole. And I'm following now with peripheral endo laser, and this is circular endo laser to avoid retina. And you still see some peripheral retinal detachment. So I'm gonna do a little more of retinotomy, because there is some sort of PVR very peripherally. So in this way, by relieving the retina, and now I'm injecting more fluorocarbon liquid, the retina is gonna come a lot more flat. As you see here, now with more fluorocarbon liquid and more endo laser, so I curb the situation and there is no slippage at the retina. It's completely attached, and now very slowly I'm going to proceed with another air fluid exchange. So you've got here inside the eye the pressure of approximately 15 millimeters of mercury. So it's very slow. I don't want to dislodge the seal, the internal limiting membrane that is tamponating the hole there. Thanks a lot. I really appreciate your attention. This is a very interesting case, and you've got the post-operative period here. The retina, the hole is completely closed. A very good case, and so this is my contact. I really appreciate. And thanks again for watching that. That was an amazing case, and I really love to watch it over and over again and introduce it to you and this technique as well. Thanks a lot.
Дуже дякую. Питання одне коротке і
дякую, чудова хірургія. Я хотіла б запитати, яку
Appreciate.
Безумовно, щиро дякую, було дуже приємно.
Якій ендотампонаді ви віддаєте перевагу при макулярних отвірах? Ну, я не маю на увазі, наприклад, тільки цей конкретний випадок, а взагалі.
Answering your question about what tamponade to use, I usually like using intraocular gas, of course, but in some cases we can use silicone oil. But intraocular gas, you go with the intraocular gas diluted, a little expensive, probably 30% through the infusion line. So by injecting the gas through the infusion line, you keep the pressure control. You do that very slowly, and you have a good feel and a good arc of contact with the gas. The patient should be head down positioning, and the surgery works well. And that's about it. So that's the way I like the technique. But again, you may use other tamponades, but I prefer, in most of my cases, the gas. I changed this idea, but that's the way.
Дуже дякуємо. І ще раз хочу подякувати за вашу таку шалену організаційну допомогу, за ініціативу і надзвичайно цікаві доповіді, які представили всі спікери сьогодні під час першого нашого спільного симпозіуму Українського альянсу офтальмологів і Retinawesome груп. Я запрошую всіх українських офтальмологів долучатися до цієї групи. Дуже багато навчального матеріалу ви зможете там побачити, тому запрошую, будь ласка, долучайтесь. Дуже дякую вам.
Thank you very much for everybody that was involved in this Retinawesome session. We are happy to participate with quality, with good cases, and we're going to be doing that always. We've got a very interesting session, interesting cases from our friends, and Athanasius, the Francini, me, and Ahmed Habib, so also Alan Franklin. So the cases were very interesting. We want to cooperate, and the Retinawesome thing is not a name for only awesome things. It's the way that we do to do the best possible for the best cases that we could cooperate and do it. Thank you very much once again.
Представників Американської академії офтальмології за затримку. Хочу